Unit 6, Autism Spectrum Disorder and Attention Deficit Hyperactivity Disorder. 6.2 Introduction. The present unit will discuss about Autism Spectrum Disorder, ASD, and Attention Deficit Hyperactivity Disorder, ADHD. You will also learn about intellectual disability and specific learning disorder in the next Unit 7. All these disorders begin in childhood and continue to adulthood. These are categorized under the broader heading of neurodevelopmental disorders, which refer to a group of severely disabling conditions considered to be a result of structural and or functional differences in the brain that are usually evident at birth or become apparent as the child begins to develop. It is important to note that one needs to be very careful about diagnosing a mental health condition in children. First, behaviors related to mental health issues and conditions might get confused with the normal typical behavior exhibited by children. Hence, one needs to be careful in diagnosis. Second, the behavior of the child always need to be discussed in the context while considering a diagnosis. To assess whether a child's behavior is normal or not, the behavior needs to be compared to a sample of children of the same age group, educational level, and socio-cultural background. For instance, temper tantrums are common in 2-year-old children but not for a 10-year-old child. Consequently, a child's behavior is understood as typical or atypical to his/her peers. Third, clinicians need to exercise care and caution in diagnosing a child. They must understand that the repercussions of the label abnormal for a child or adolescent are immensely stigmatizing and has significant implications in determining the future outcomes for the child as an adult. 6.3 Autism Spectrum Disorder. The term autism is derived from the Greek word autos, meaning self, used by Eugen Bleuler, Swiss psychiatrist, for the first time. Autism is a neurodevelopmental condition that is usually identified before a child is 30 months of age and may be suspected in early weeks of life. Autism is a condition that affects social communication and is associated with repetitive patterns of behavior. DSM-5 has combined 4 independent diagnoses, that is, autistic disorder, Asperger syndrome, pervasive developmental disorder not otherwise specified, PDD numbers, and childhood disintegrative disorder into one diagnosis of autism spectrum disorder, ASD. Recent researches have suggested that all these disorders have the same essential symptoms, varying in degrees of severity. No two children with ASD are alike. They have wide range of deficits, abilities, difficulties, and challenges. Therefore, spectrum was found to be a suitable word to describe individuals with autism. Box 6.1. Case study, Autism Spectrum Disorder. Abhishek is 5 years old. His mother took him to a doctor to get his hearing tested at 2 years of age when he would not respond to his name and had not started speaking even a single word. Even at 5 years of age, Abhishek would turn his head away whenever someone would speak to him. Sometimes he would mumble something unintelligible. Although toilet-trained and able to feed himself, schools asked his parents to take him out of school, because Abhishek would not mingle with other children. He actively avoided being touched and, on some days, he would start to cry and scream and no amount of cajoling or loving him would soothe him. Inconsistent eye contact and repetitive behavior like lining up of his toy cars can be seen. When seated, he often rocks back and forth in a rhythmic motion for hours. Any change in routine is highly upsetting to him. 6.3.1 Clinical picture in ASD. Lack of reciprocal social interaction is amongst the earliest markers of autism, irrespective of cognitive or language ability. In infancy, the child seems to be aloof from others. Mothers remember that babies diagnosed with autism later in life fail to respond to their name, do not reach out when picked, would never smile or look at family when they are played with, or may not notice people, family and strangers alike coming and going from the room. This may make people assume that children with autism do not have the ability to express emotions or may lack emotions. However, the fundamental problem in autism comes from lack of social understanding. As children with autism grow older, deficits in social understanding can be seen in lack of initiation for social interactions with others. Social interaction is restricted to getting obvious needs met such as food and water. The children appear to be content with being alone and may ignore parents' bid for attention, and inconsistent eye contact, although not reported for all children, but has been reported for many children on the spectrum. Some children may approach others in an unusual manner, for example, by licking, smelling or biting. In teenagers, the social deficits are not manifested in seeming lack of social interest, but in inability to maintain relationships appropriate to age level. This is because in adolescence, an individual is faced with a more complex social milieu. A person on the spectrum may lack the ability to understand social conventions, making socialization extremely challenging. For instance, the person may have difficulty in understanding jokes, irony, sarcasm, and faux pas, and because of this may become a victim of bullying in school. Individuals with autism find it difficult to understand and use verbal and nonverbal communication. Deficits in verbal communication include delay in language development, mutism, inability to acquire speech, idiosyncratic uses of speech, unusual ways of using some words, immediate or delayed echolalia, repetition of words or phrases either immediately or later sometime, or inability for pragmatic use of speech, inability to use language for everyday social interactions. Individuals with autism may fail to initiate, maintain, or respond to conversations, engage in one-sided conversations, which makes others who have no understanding of autism to reject them. Additionally, children with ASD find it challenging to understand nonverbal gestures, cues, and body language of others. About 70% of human communication is largely nonverbal in nature. Deficits in verbal and nonverbal communication prove to be a major impediment for successful socialization even for extremely intelligent people on the spectrum. Box 6.2 DSM-5 Criteria for Autism Spectrum Disorder, APA, 2013. A persistent deficits in social communication and social interaction across multiple contexts, as manifested by the following, currently or by history. Examples are illustrative, not exhaustive. See text 1. Deficits in social emotional reciprocity, ranging, for example, from abnormal social approach and failure of normal back and forth conversation, to reduced sharing of interests, emotions, or affect, to failure to initiate or respond to social interactions. 2. Deficits in nonverbal communicative behaviors used for social interaction, ranging, for example, from poorly integrated verbal and nonverbal communication, to abnormalities in eye contact and body language or deficits in understanding and use of gestures, to a total lack of facial expressions and nonverbal communication. 3. Deficits in developing, maintaining, and understanding relationships, ranging, for example, from difficulties adjusting behavior to suit various social contexts, to difficulties in sharing imaginative play or in making friends, to absence of interest in peers. Be restricted, repetitive patterns of behavior, interests, or activities, as manifested by at least two of the following, currently or by history. Examples are illustrative, not exhaustive. See text 1. Stereotyped or repetitive motor movements, use of objects, or speech, for example, simple motor stereotypies, lining up toys or flipping objects, echolalia, idiosyncratic phrases. 2. Insistence on sameness, inflexible adherence to routines, or ritualized patterns of verbal or nonverbal behavior, for example, extreme distress at small changes, difficulties with transitions, rigid thinking patterns, greeting rituals, need to take same route or eat same food every day. 3. Highly restricted, fixated interests that are abnormal in intensity or focus, for example, strong attachment to or preoccupation with unusual objects, excessively circumscribed or perseverative interests. 4. Hyper or hyporeactivity to sensory input or unusual interest in sensory aspects of the environment, for example, apparent indifference to pain/temperature, adverse response to specific sounds or textures, excessive smelling or touching of objects, visual fascination with lights or movement. These symptoms must be present in the early developmental period, but may not become fully manifest until social demands exceed limited capacities, or may be masked by learned strategies in later life. These symptoms cause clinically significant impairment in social, occupational, or other important areas of current functioning. These disturbances are not better explained by intellectual disability, intellectual developmental disorder, or global developmental delay. Intellectual disability and autism spectrum disorder frequently co-occur. To make comorbid diagnoses of autism spectrum disorder and intellectual disability, social communication should be below that expected for general developmental level. Social and communication deficits have a reciprocal relationship in autism. An innate inability for socialization affects language development in the child. Language and communication deficits in turn lead to challenges with socialization as the child grows up. Understanding of this reciprocal relationship between socialization and communication deficits led DSM-5 to assimilate socialization and communication impairments under a single heading, social communication impairments. Social communication impairments in autism have been attributed to the inability of individuals with autism to read people's minds, also known as mind blindness. Mind blindness refers to the difficulty in seeing things the way other people do and make educated guesses about what others may be thinking or feeling. This skill helps typical people navigate a number of social situations. For instance, if a typical child finds her/his friend sitting and sulking, she/he is likely to inquire about the reason for her/him sulking, whereas a child with autism may be unable to read the nonverbal gestures of sulking and start talking about a topic that greatly interests him/her. Fig. 6.1, Nonverbal communication. Along with social communication difficulties, autism is characterized by a number of behavioral difficulties in autism. Children with autism may engage in stereotyped or repetitive speech, motor movements, or use of objects. For instance, they may engage in self-stimulation, i.e. repetitive movements as head banging, spinning, and rocking, which may continue by the hour. Lining up of objects is also commonly seen in children. Excessive adherence to routines or rituals and resistance to changes in routines can also be seen with children on the spectrum. The child may insist of taking the same route every day, or make the bus stop at a particular point, only then would the child get down. Children may form strong attachments to unusual objects like rocks, keys, and light switches, so much so that the attachment may interfere with other activities. Highly restricted interest of unusual magnitude is not just limited to objects such as pens, keys, action figures, and particular toys, but may also extend to topics like dinosaurs or trains. Changes in the environment, stereotypical routine, and or an object with strong attachment leads to resistance from the child ranging from discomfort to crying spell that continue until the situation is restored. Finally, an addition to DSM-5 diagnostic criteria for autism is sensory difficulties. Sensory difficulties, i.e., hyper or hyporeactivity to sensory input from the environment such as indifference to pain /heat /cold, over-under-reaction to certain sounds, distaste for certain food to the point of being nauseous when made to eat it, fascination with lights etc. are pervasive and independent of age and ability. Although individuals with autism have always experienced sensory hyporeactivity, practitioners have only recently acknowledged it, because of the social communication difficulties inherent in autism. For instance, a child with autism would cry when getting hair or nails cut, he may refuse to wear socks, or t-shirts with labels because of hypersensitivity to tactile stimuli. But many adults would interpret this as disruptive behavior instead of sensory difficulties in autism. Autism has a high comorbidity with intellectual disability. Earlier estimates indicated that approximately 70% of individuals with autism also had intellectual disability, Fomborn, 2005. However, recent estimates have estimated that 50% of individuals with autism are also intellectually impaired, Polinak, Kubiner and Gyararajan, 2005. This shift in the distribution has been primarily attributed to an increase in identification of high-functioning children with autism, who were earlier missed out because their cognitive abilities would often mask other deficits. Unlike children with intellectual disability, children with autism are quite adept at puzzles and fitting objects together, often performing better than even typical children. However, difficulties meaning is apparent. For instance, if a child with autism is asked to arrange pictures in an order so that they communicate a story, he is likely to perform poorer than typical children. 6.3.2 Causal factors and treatment of ASD. Although most scientists believe that autism is an innate condition that affects the development of the nervous system of a child, the precise causes of autism are unknown. Evidence from role of genetics in the etiology of autism comes from studies examining the incidence rates of autism in families. To have a parent or sibling with autism raises the chance of an individual to have autism. According to WHO, 1 in 160 children has ASD. A family with one child with autism have greater risk of having another with autism. Twin studies have shown higher concordance for monozygotic, 60%, than dizygotic twins. Relatives of people with autism may show subthreshold social communication deficits. Genetic researches in autism has been found autism to be related to the faulty working of the brain's glutamate neurotransmitter system. However, it is unclear how the genetic vulnerability transmits to leads to faulty wiring in early stages of development. Expression of the autism genes may be influenced by environmental factors. Prenatal environmental factors, exposure to radiation, toxins, alcohol, drugs, infections etc., and pregnancy-related factors, uterine bleeding, Rh incompatibility, induced or prolonged labor, oxygen requirements at birth, have been implicated in children with autism. Based on the recent researches, it is important to note that there is no cure for autism. In spite of that, many children continue to be subjected to the many fads in the market, promising them a cure for the condition. Many researchers and parents conceive autism to be unlike other mental illnesses like depression and anxiety. Autism is seen as a condition that leads to differences in brain wiring relative to the typical population. Treatment of autism includes management of problematic behaviors as well as training of teachers, schools, and workplaces to understand and make space for the challenges of autism. In the past, medications for autism have proven to be effective. Currently, medicines are only prescribed for aggression and hyperactivity that may be excessive and leading to self-harm. Behavioral therapy has been found to be successful in development of some social and communication skills and elimination of problematic behavior. A successful intervention involves one-to-one teaching of skills every day for several years in diverse settings of the child, i.e. clinic, school, and home. Adults, including parents and teachers, are taught principles of behavioral therapy, such as use of rewards and breaking down of complex tasks into smaller tasks. Use of punishment or aversive techniques must be avoided. 6.4 Attention Deficit / Hyperactivity Disorder. Children with attention deficit / hyperactivity disorder, ADHD, display difficulties in maintaining sustained attention, excessive and exaggerated motor activity, and impulsivity relative to their developmental level, leading to social, occupational / academic activities. DSM-5 classification lists it as a neurodevelopmental disorder. It specifies several inattentive or hyperactive impulsive symptoms to be present prior to 12 years of age and can be classified in terms of the current severity as mild, moderate and severe. There are three subtypes of attention deficit / hyperactivity disorder, such as combined presentation, predominantly inattentive presentation, attention deficit disorder, AD, and predominantly hyperactive / impulsive presentation. ADHD combined type is the most common presentation, whereas ADHD predominantly inattentive type may be cases of pure AD or may include children who display attention difficulties along with subthreshold hyperactivity. 6.4.1 Clinical picture in ADHD. Attention deficit is a multidimensional construct that includes problems with arousal, alertness, selective focus, sustained attention / vigilance, and distractibility. These difficulties can manifest in many situations, making it difficult to function adequately in school, workplace, or with friends and family. Issues with arousal and alertness can lead to children failing to give attention to details, losing track of time or things, making careless mistakes, or daydreaming. A child with deficit selective attention is likely to fail to understand instructions and follow through instructions. She / he could appear to others as if she / he is not listening or that their mind is elsewhere. Problems with sustained attention can most often be seen in boring and repetitive activities but can also be apparent in free play. The child has a tendency to tune out of these tasks, and tasks requiring sustained attention, for example reading, mathematics, board games, etc., are seen as aversive and are generally avoided. Sustained attention deficits may lead the child to shift from one task to another without completing any one of them. Finally, distractibility is the ability to be easily attend to irrelevant stimuli in the environment, for example noise, background conversations, object in a room, etc. Attentional difficulties affect daily lives of people with ADHD. Their work is often messy, disorganized, and appears to have been done without any considered thought. School material like pen, tiffin boxes, books and notepads are often scattered, lost or damaged. Attentional problems also make children and adolescents forgetful. For instance, they would forget to bring lunch, books, homework, etc. Socially, ADHD individuals find it difficult to keep track of conversations. Such children often find it challenging to follow rules in games or different activities. Fig. 6.3 Descriptions used by parents and teachers for children with significant attentional difficulties. Hyperactivity refers to excessive activity manifested in two forms: motor hyperactivity, restlessness, squirminess, and unnecessary body movements, and vocal hyperactivity, excessive talking. Manifestation of hyperactivity may vary with developmental level. In preschool children, hyperactivity can be seen in children to engage in excessive jumping and climbing on furniture, running around the house, and in difficulty in engaging the children in sedentary activity like listening to story. In school-aged children, similar behavior may be seen in hyperactive children, although the behavior may be lesser in intensity and frequency. Hyperactivity in children can be seen in the child's difficulty to remain seated. They get up frequently, squirm, and hang on to the edge of their seat. Not only do they fidget during academic activities, they also find it challenging to sit through meals, TV, or play that requires them to sit in one place. One is likely to find them fidgeting with objects, pen, or shaking legs. Girls with ADHD are more likely to display hyperactivity through excessive talking and interruptions when others are talking. It is a common misbelief that adolescents/adults outgrow their hyperactivity. However, in older children, hyperactivity manifests more as restlessness, excessive speech, difficulty in engaging in solitary activities, and increased aggression and conflicts. Professionals stress on pervasiveness of hyperactivity. ADHD children display hyperactivity throughout the day and even during night. ADHD children find it difficult to fall asleep and may wake up early. Hyperactivity is pervasive and displayed in all domains including home, school, and playground. Impulsivity is one of the most common complaints parents and teachers make about children with ADHD. Impulsivity refers to the tendency to act on urges, apparently without thinking. Most common complaint made about children with ADHD by parents and teachers is about this symptom. Impulsivity can be seen in impatience, difficulty in waiting for their turn, interrupting and intruding others to the point of causing difficulties in school, social or occupational setting. Impulsivity is often responsible for the many accidents that hyperactive children get into. More often than not, children with ADHD may knock over objects, bang into people, grab to hold a hot pan, or even engage in potentially harmful activity like repeatedly climbing trees and riding bicycle in traffic. Children with ADHD also display some secondary problems. ADHD is related to cognitive and academic difficulties, as children with ADHD are found to have delay in intelligence of about 7 to 10 IQ points, may be at high risk for learning disability, and have lower academic intelligence than their peers. Many children with ADHD suffer from socio-emotional difficulties also. There is high rate of rejection by peers amongst ADHD children, which is not because they are unfriendly but because ADHD may make them inattentive to social cues, and peers may get tired of their hyperactivity and excessive talking. Unpopularity amongst peers may also be a result of aggression and depression. Peer rejection and negative criticism from parents and teachers negatively affects the self-esteem of these children. Box 6.3, Case Study, Attention Deficit Hyperactivity Disorder. Ruben is a 9-year boy who has been referred to a child psychologist at the request of his school counselor. The counselor had been receiving multiple complaints about Ruben from his class teacher. The teacher complained that Ruben is extremely restless. He is hardly ever on his seat and roams around in the class in spite of the many instructions given against getting up in class. He finds it difficult to pay attention to lessons in class, and his work is messy and incomplete. His restlessness disturbs other children. Sometimes, he talks to other students, making it difficult for them to concentrate on their individual classwork. The teacher reports that Ruben does not seem to have any control over his unpredictable behavior and is quite polite and good-natured. Clinical interview with parents revealed that Ruben has had behavioral difficulties ever since he was a toddler. Even when he was 3 years old, he was and extremely restless who required little sleep and woke before anyone else. When he was 4, he had managed to unlock the door of the house and wandered off by himself on a busy road. He was brought back by a neighbor who found him wandering on the streets. Teachers in play school complained that Ruben would find it difficult to follow any instructions given to him, and his restlessness made it difficult for the teacher to look after his well-being. The prevalence rate of ADHD has been increasing over the years. The average prevalence of ADHD worldwide is found to be 5.9, 7.1% and 2.6, 4.5%, Willicott 2012, Polanczyk et al. 2015. Some researchers believe that the increase in the number of children diagnosed with ADHD may be a result of an increase in awareness about ADHD or society's intolerance to childhood activities because of urban life pressures and loss of support, or extended family. Also, boys are 3 times more likely to be diagnosed with ADHD. This may be because adults may be more tolerant of hyperactivity in girls who engage in less direct aggressive. Secondly, research on ADHD has focused on boys, thereby ignoring the experience and manifestation of ADHD symptoms in girls. There is high comorbidity of aggression and depression in ADHD. Box 6.4, DSM-5 Criteria for ADHD, APA, 2013. A persistent pattern of inattention and / or hyperactivity impulsivity that interferes with functioning or development, as characterized by 1, and / or 2 inattention, 6, or more, of the following symptoms have persisted for at least 6 months, for children up to age 16. To a degree that is inconsistent with developmental level and that negatively impacts directly on social and academic / occupational activities. Note, the symptoms are not solely a manifestation of oppositional behavior. Defiance, hostility, or failure to understand tasks or instructions. For older adolescents and adults, age 17 and older, at least 5 symptoms are required. A. Often fails to give close attention to details or makes careless mistakes in school work, at work, or during other activities. For example, overlooks or misses details, work is inaccurate. B. Often has difficulty sustaining attention in tasks or play activities. For example, has difficulty remaining focused during lectures, conversations, or lengthy reading. C. Often does not seem to listen when spoken to directly, for example, mind seems elsewhere, even in the absence of any obvious distraction. D. Often does not follow through on instructions and fails to finish school work, chores, or duties in the workplace, for example, starts tasks but quickly loses focus and is easily sidetracked. E. Often has difficulty organizing tasks and activities. For example, difficulty managing sequential tasks, difficulty keeping materials and belongings in order, messy, disorganized work, has poor time management, fails to meet deadlines. F. Often avoids, dislikes, or is reluctant to engage in tasks that require sustained mental effort, for example, schoolwork or homework. For older adolescents and adults, preparing reports, completing forms, reviewing lengthy papers. G. Often loses things necessary for tasks or activities, for example, school materials, pencils, books, tools, wallets, keys, paperwork, eyeglasses, mobile telephones. H. Is often easily distracted by extraneous stimuli, for older adolescents and adults, may include unrelated thoughts. I. Is often forgetful in daily activities, for example, doing chores, running errands. For older adolescents and adults, returning calls, paying bills, keeping appointments. 2. Hyperactivity and impulsivity. 6 or more of the following symptoms have persisted for at least 6 months, children up to the age of 16 years, to a degree that is inconsistent with developmental level that negative impacts directly on social and academic /occupational activities. Note, the symptoms are not solely a manifestation of oppositional behavior, defiance, hostility, or a failure to understand tasks or instructions. For older adolescents and adults, age 17 and older, at least 5 symptoms are required. A. Often fidgets with or taps hands or feet or squirms in seat. B. Often leaves seat in situations when remaining seated is expected, for example, leaves his or her place in the classroom, in the office or other workplace, or in other situations that require remaining in place. C. Often runs about or climbs in situations where it is inappropriate. Note, in adolescents or adults, may be limited to feeling restless. D. Often unable to play or engage in leisure activities quietly. E. Is often on the go acting as if driven by a motor, for example, is unable to be or uncomfortable being still for extended time, as in restaurants, meetings, may be experienced by others as being restless or difficult to keep up with. F. Often talks excessively. G. Often blurts out an answer before a question has been completed, for example, completes people's sentences, cannot wait for turn in conversation. H. Often has difficulty waiting his or her turn, for example, while waiting in line. I. Often interrupts or intrudes on others, for example, butts into conversations, games, or activities, may start using other people's things without asking or receiving permission, for adolescents and adults, may intrude into or take over what others are doing. B. Several inattentive or hyperactive impulsive symptoms were present prior to age 12 years. C. Several inattentive or hyperactive impulsive symptoms are present in 2 or more settings, for example, at home, school, or work, with friends or relatives, in other activities. D. There is clear evidence that the symptoms interfere with, or reduce the quality of, social, academic, or occupational functioning. E. The symptoms do not occur exclusively during the course of schizophrenia or another psychotic disorder and are not better explained by another mental disorder, for example, mood disorder, anxiety disorder, dissociative disorder, personality disorder, substance intoxication or withdrawal. 6.4.2 Causal factors of ADHD. Researchers understand that the causes of attention deficit hyperactivity disorder are not social in origins. Genetic factors play a role in ADHD as twin and family studies report high degree of heritability of ADHD. Adoption researchers have also reported higher rates of hyperactivity in biological parents of hyperactive children than adoptive parents of such children. Molecular genetic studies have found that multiple genes contribute to the risk for ADHD. In particular, that one or dopamine transporter gene has been implicated. Neuropsychological studies have found structural and functional difference in brains of people with ADHD and typical control. In particular, difference have been seen in frontal lobe, basal ganglia, and cerebellum. Executive functions, high-order cognitive processes, such as working memory, attention, and inhibition of responses has been found to be poorer for ADHD individuals relative to typical control. ADHD is related to dysfunction in 2 neurotransmitters, dopamine and norepinephrine. Scientists have found that inattention and distractibility appear to be related to low levels of norepinephrine, whereas impulsivity and hyperactivity problems appear to be related to low levels of dopamine in the brain. Thus, because child feels lack of stimulation in the brain, hyperactivity is a way to compensate for that. That is why, stimulants are prescribed as medicines for children with ADHD. Pregnancy and birth factors like mother's age at delivery, younger, mother's educational level, lower, time between labor, longer, and premature delivery related to higher probability of the child developing ADHD. Prenatal exposure to environmental toxins like lead, alcohol and tobacco have been implicated. Certain medicines, such as medicines for seizures, are likely to result in problems with inattention and hyperactivity. Some researchers also report that the behavior of some ADHD children is worsened after eating foods with artificial colors, certain preservatives, and or allergens. While social factors like parenting style, schooling, and peer relations may moderate the types and degrees of impairment, but they do not cause ADHD. Overall critical, harsh and negative behavior of parents of hyperactive children is related to difficult, disruptive and non-compliant behavior of ADHD children. Early television viewing has also been found to shorten attention span of children. Aggressive and hyperactive portrayal of characters in TV shows has also been found to exaggerate difficult behavior. 6.4.3 Treatment of ADHD. Some of the treatment options for ADHD are indicated below. Prescription of medicine like Ritalin, methylphenidate, and amphetamine in some children with attention deficit hyperactivity disorder is a common treatment for ADHD. Ritalin is a stimulant and has a quietening effect on a child with ADHD, opposite of what is expected for a typical adult for whom stimulant leads to increased arousal and experience of excess energy. Ritalin has been found to help children reduce restlessness and aggression, helping them focus on studies and moderate difficult behaviors in classroom and home. Some significant side effects are also related to the use of Ritalin in children, including decreased blood flow to the brain, which can result in impaired thinking ability and memory loss, disruption of growth hormone, leading to suppression of growth in the body and brain of the child, insomnia, psychotic symptoms, and others. Medicines like Ritalin do not cure ADHD, but they do result in moderation of behavioral symptoms. Psychological interventions along with medications are important in providing holistic treatment. Behavioral strategies include selective reinforcements in classroom and structuring of material in a way that enhances the experiences of success. For instance, a girl with ADHD should be praised for increasing the amount of time she sits in classroom, even if she sits for 15 minutes in a half an hour class, if she was unable to previously sit for anything more than say 5 minutes. Family therapy helps in making parents and siblings understand behavioral strategies to maximize productive behavior and extinction of aggressive and destructive behavior. School-based intervention programs aim to teach teachers to deal with hyperactivity and inattention difficulties in classroom. 6.5 Let us sum up. In the present unit you learned about two of the important developmental disorders that can affect children. These are autism spectrum disorder, ASD, and attention deficit hyperactivity disorder, ADHD. These are also called neurodevelopmental disorders which have a heritable component. You learned about exercising care and caution while diagnosing mental health conditions in children and adolescents. The unit presented the clinical picture in ASD. Autism is a condition that affects social communication and is associated with repetitive patterns of behavior. Although there is no cure for autism, behavioral interventions and parent/teacher training program can help with problematic behaviors of children with ASD. Behavioral therapy has been found to be successful in development of some social and communication skills and elimination of problematic behavior in autism spectrum disorder. You also learned about the diagnostic features, causal factors and treatment in case of ADHD. Children with attention deficit hyperactivity disorder display difficulties in maintaining sustained attention, excessive and exaggerated motor activity, and impulsivity relative to their developmental level, which affects their academic, social, and occupational activities. Various psychological and school-based interventions for the treatment of ADHD were also discussed.